Good afternoon to everyone. I hope you can all hear me clearly. We are about to begin our session. Okay, my name is Dr. Kevin Raphael, the coordinator for this Safe Surgery and Anesthesia Care Eco Sessions. And I'm gladly welcoming all of you who have attended, who have joined our session today. Today is a clinical session, which is going to be led by JHPIEGO, and it's going to be an interesting learning session. Now, as usual, I would like to just share the etiquette for echo sessions with you. Always make sure if you're not speaking, your microphone is muted. If you are given a chance to speak, make sure you unmute your microphone before. And the function for muting and unmuting is at the left bottom corner of your screen. Also, make sure that you do not have a light source, a bright light source from the back, which will cause a visual interference. And if you have any issues or questions, make sure you send your questions or issues through the chat. After saying that, I would like to share with you the agenda of the session today. As I said, our lead partners are going to be JHPIEGO, and today is a clinical session and a surgical skills training. Our main objective for the day is going to be on the discussion of surgical management of postpartum hemorrhage. As usual, we are going to begin with the introduction of key participants and welcome remarks. And then we are going to be followed by a 20-minute patient case presentation, which is going to come from Bukoba Regional Referral Hospital in Kagera region. And our presenters are going to be Dr. Emmanuel Gitambi and Johannes Josiah, who are the part of the surgical team at Bukoba. And they are going to present on a case of a patient who had a postpartum hemorrhage with ruptured uterus. After listening to the case presentation, we are going to have a brief 5-minute period for questions. So I'm going to encourage all the participants to listen carefully and prepare questions so that we can have an interactive discussion at the end. So after the patient case, we are going to have questions. And then after brief questions, we are going to have now a didactic presentation, which is going to be led by Dr. Albert Kihundwa, who is an obstetrician and gynecologist at Bugando Medical Center. And he's going to take us through the surgical management of postpartum hemorrhage. After the didactic, then we are going to have a overall discussion. We are going to allow comments, any recommendations from the participants in the spoke hospital also we are going to allow. And then at the end, we are going to have concluding remarks and announcements. Now, before I continue further, I would just like to make one announcement, which is an important announcement at the beginning of the session. We have, ECHO will be expanding to 15 more sites in Mara region and 15 more sites in Kagera region. So our ECHO platform, I think from the beginning of April, we are going to have 40 health center and hospitals who are going to be regularly joining our session. So it's going to be a big platform, and we're excited about that. Currently, we are working at Mara region to do the assessment of these facilities who are going to be to join us in April, hopefully. After saying that, I would like to welcome the JHPIEGO team who are the lead partners for today. Please introduce yourselves, and then we will go on with the agenda.
Hi, habari za mchana. Naitwa Dr. Leopold, niko JHPIEGO Dar es Salaam.
Hi everyone, this is Mark Hathaway from JHPIEGO headquarters in Washington, D.C., Baltimore.
Good afternoon, everyone. This is Agustino from JHPIEGO Dar es Salaam, currently with the team at Buguruni Health Center in Dar es Salaam. So, Doctor, I just wanted them to also see our sessions.
Thank you so much, JHPIEGO team. Dr. Hela, thank you so much for inviting the Buguruni surgical team to join our session. We are glad to have them. I don't see any Assist International members, so I'm going to welcome also Dr. Albert from Bugando, who is our didactic lead for today, to introduce himself briefly. Dr. Albert, please introduce yourself briefly.
Good afternoon, everyone in East Africa, and good morning, Mark, in the US. I'm Dr. Albert. I'll be here in the echo session for today. Thank you.
Thank you, Dr. Albert. So according to our agenda, we are going to begin with the team from Bukoba Regional, Dr. Jitambi, who is going to take us through the patient case presentation. Dr. Jitambi, please welcome, introduce yourself and your team, and proceed with the presentation.
Thank you. My name is Dr. Jitambi Emmanuel from Regional Hospital. Of the surgical team. Our presentation of a mother of 43 years.
Sorry, Dr. Jitambi, I would just like to ask, tunamsikia vizuri presenter?
Inakwama lakini anasikika.
Okay. Screen yake aloshare, tunaona content aloshare?
Hapana, screen is black.
Bado.
Okay. Dr. Jitambi, kuna shida ya kushare, naweza nikakusaidia kushare screen.
To mute here.
Can you see the screen now? Hello.
Okay, nadhani mnaweza mkawa na network problem. Sioni screen yako. Hebu stop sharing, ngoja mimi nikusaidie kushare, alafu tutaendelea.
Okay.
Okay, Dr. Jitambi, unaona screen nimeshare presentation?
No, I can't see anything. It is black.
Okay. Participants wengine mnaona screen?
Yes, sisi tunaona huku. Nafikiri ni resolution. Mtaalamu ananiambia hapa resolution ya screen yake huko, angalia.
That's right. Hello.
Yes, Dr. Jitambi, unaona sasa screen?
Sisi tunaona.
Dr. Jitambi, can you see the presentation? I think their network might be not stable.
Hello.
Yes, Dr. Jitambi, tunakusikia.
Hello.
Tunakusikia. Sijui unaona screen tumeshare?
Okay. Yeah, naiona sahihi.
Okay, you can proceed.
Network.
Okay. She was 40. She's 43 years old. The 5 para 4 living 4. All has continuous vaginal delivery, and her last normal menstrual period was of 24 of April 2019. Her gestation age was 38 weeks plus 2 days, and date of admission was on 21 January 2020, and procedure was done on 22 January 2020. Date of discharge was on 26 January 2020. Next. Next, January 2020 at 8:25 p.m. She presented with labor pain since 4 p.m. With no edema, 5 hours. For the examination of the patient, the vitals, the patient was in February with body temperature of 6 degrees Celsius.
Dr. Jitambi, we cannot hear your presentation.
Was 4.
Try to stop your video.
With moderate contractions.
Try to stop your video and then go on presenting without the video on. That will help a bit, okay?
Okay. The cervix on the PD examination, the cervix was soft and thick, 3 to 4 centimeters, with no couple, no molding. Next. Antenatal history, the man would be at 20 weeks gestation age. She made total number of visits. Syphilis screening was non-reactive. The mother was PMPCD2, and group O letters positive. She received the TT1 and TT2 plus SP as for malaria prophylaxis. The urine protein was checked regularly and was negative. Fellas, she received the loss of fellas and the folic acid during the 6th and outer period. Next. History. And her past medical history, there's no history of chronic illness in the family, and there's no family history of chronic illness. Next. Management of first stage of labor continues the safe, effective use of photograph, and no argumentation was done. On the 22nd January at 1:40 a.m., 5 hours after admission and 9 hours in the hour, the mother had spontaneous vertex delivery of female baby with APGAR score of 9 and 10, of 9 in 30 minutes and 10 in 50 minutes, who weighed about 2.8 kilogram. First stage duration was 9 hours, and the second stage 10 minutes, and the third stage 3 minutes. She was given oxytocin 10 international IV start, and placenta membrane were completed delivery by controlled contractions. Uterus was moderately contracted, and the perineum there was no tear. It was intact. Blood loss was approximately about 200 mils. Next. At 3 hours, 3 hours post-SVD at 5 a.m., Dr. Ngo informed me to review the mother who was complaining of severe abdominal pain with moderate PV bleeding. On examination, the patient was alert, restless, confused with Glasgow Coma scale of 13 over 15, where motor was 5, verbal was 4, and the eye was 4. Vitals blood pressure was 84 over 46 millimeter of mercury, with mean arterial pressure of 58. Pulse rate was 1.4 beats per minute, and oxygen saturation was 92% in the room where, with respiratory rate of 22 cycles per minute. On per abdomen, the uterus was both with the minimal tenderness and fresh PV bleeding per vagina. Next. Next slide. We came with an impression of hypovolemic shock secondary to ruptured uterus. The plan was to mobilize the theater team for emergency laparotomy, urgent HB blood grouping and a cross-match, where was the HBM was 11.5 gram per deciliter, and the blood grouping and the cross-match, prepare one unit of whole blood and FFP, and the consent form was signed by relative because the patient was restless and confused, and also pre-op management was IV ampicillin 2 gram start, and then there's lactate 4 liters IV. Next. During the procedure, anesthesia technique was less and comparative. Approach for laparotomy was STUMI, subapical midline incision. Findings during findings during the operation, there was a pool of fresh blood in the peritoneal cavity, approximately 1 liter, and the blood was full of large kidney dish. There was uterine rupture on the right side, which was non-repairable, and urinary bladder was intact. What was done during the operation, suction of fresh blood and evacuation of blood clots, and subtotal hysterectomy was done successfully. Hemostasis was achieved.
Nyerere DDH, sorry to interrupt you, Dr. Jitambi. Nyerere DDH, make sure your microphone is muted. Continue, doctor. Mute your microphone, Nyerere DDH. Doctor, continue.
Let's move to the next slide. Okay, thank you. post-op management to take vitals every 15 minutes. And the IV ring lactate 3 liters for 24 hours. Injection method in IM 100 milligrams that IM 1 gram 6 hours for 24 hours, and the metronidazole 100 milligrams TDS and TAPS ibuprofen 400 milligram BID for 7 days, and to monitor fluid input and output by charting, and also transfuse 2 of whole blood and 1 unit of FFP. Next. On the first day the patient was reviewed. She was complaining of pain on the incision site. There was no headache, no fever, no dizziness, or difficulty in breathing. On examination, the temperature was 36 degrees Celsius, heart rate was 80 beats per minute, blood pressure was 120, and the respiratory rate was 18 cycles per minute. Abdomen, the incision site was dry, abdomen was not distended, and it was soft with just mild tenderness.
Nyerere DDH, I would like to ask, sorry doctor to interrupt you. I think there's a person in Nyerere who is unmuting the microphone. Please stop doing that. It will cause interference until the time for asking questions. Okay, Dr. Jitambi, please go on.
Okay. The plan for management was the IV ampicillin 2 gram IV 6 hours for 48 hours, and IV metronidazole 500 milligram 80 hours for 48 hours, and IM pethidine 50 milligram start, and monitor vitals 4 hours. Next slide. On the second day post-operation, the patient was doing fine, and she was only complaining of pains at the incision site. There was no abdominal distension, no fever, no headache, and there was no dizziness. On general examination, the vitals blood pressure was 111/67 millimeters of mercury. Pulse rate was 79 beats per minute. And per abdomen, the wound was clean, soft with mild tenderness, and the urine was clear. Plan was to retain the catheter and encourage ambulation and start soft diet and continue with the treatment. The antibiotics. Next slide. On the first day post-operation, the patient was reviewed. She had no complaints, and she was ambulating, and she reported to pass stool, vitals. She was febrile. Blood pressure was 159/97 millimeters of mercury, and the pulse rate was 89 beats per minute. Per abdomen, the wound was clean and dry, and also the baby was doing fine with the body temperature of 36.5 degrees Celsius. The respiratory rate was 32 cycles per minute, and the umbilical cord was dry with no discharge. Plan was 1 tab per hour OD for 1 month, and to discharge home to come back on 28th at the health facility. Next slide. On summary, I was presenting to you a 43 years old, gravida 5, para 4, living 4, or spontaneous vaginal delivery, admitted with labor pain at 38 weeks gestation age, who had good progress of labor for 9.5 hours, followed by spontaneous vaginal delivery, female baby of 2.8 kilogram, and who scored 9 in 1st minutes and 10 in 5th minutes. Third stage completed well, and was given a IV of 10 international unit. Start 3 hours post delivery, she developed uterus. Lateral uterus was suspected. Uterus, hemoperitorium 1 liter, and a lot of clots. Subtotal hysterectomy was done under general anesthesia, and the patient recovered well on the combination of antibiotics. And on the first day, the patient was discharged in a good condition. But she didn't turn back for 4 hours. Thank you. Hello.
Dr. Jitambi, thank you. Tunashukuru sana kwa presentation nzuri, na pia tumependa tuwapongeze kwa ajili ya kusave maisha ya huyu mama pamoja na mtoto wake. It was a congratulations to your team at Bukoba Regional Referral for the management of this patient. Now we are going to allow questions from the participants. Yes, if anyone has a question regarding the case presentation from Bukoba, I can give you a chance to ask your question now. If you cannot ask it now, you can write your question through the chat, and then we can discuss it later during the discussion part. So I would like to welcome anyone with a question. Kwa mtu yoyote mwenye swali kuhusiana na case presentation iliyopita. Okay. Basi kwa mwenye swali kuanzia sasa hivi utahakisha unaandika swali lako kwenye chat unalituma. Okay, I think Dr. Mark has a question. Dr. Mark, please welcome with a question.
Hi, everyone. Thank you so much for not only saving this woman's life, but also a comprehensive and complete presentation. It was great. My question is, was the woman monitored after delivery? And it looked like there was about 3 hours before she started complaining. And I'm wondering if the team, not necessarily the surgical team, but the hospital team after she delivered, was she being monitored for vitals and vaginal bleeding? And is it possible that could it have been detected, proceeding to shock, could it possible it be detected prior to the complaint from the woman? I'll mute myself. And
okay, thank you, Dr. Mark, for the, I think, very good question. And I think the Bukoba team have heard the question, and we are going to discuss it during the discussion period. So we are going to bring up this question during the discussion phase again, and then we are going to allow our fellows from Bukoba to respond.
Great, thanks.
Okay. So after saying that, other participants with questions, you can send them through the chat. Okay, anyone else who would want to? Okay, so I would like to welcome now Dr. Albert, who is going to take us through the didactic presentation. Dr. Albert, please welcome.
Thank you, Dr. Kevin. Good afternoon to everyone in East Africa, and good morning to Mark. Thanks, Bukoba, for the nice presentation and for sharing with us. But also thanks very much for your efforts in trying to detect that the mother had postpartum hemorrhage, and for all the good work that you did to save her life. To start with, let me just take you through the map or the objectives that I'm going to put in front of you today. Next. Yeah, I just want us to review the steps and reinforce on the skills on how to manage PPH due to uterine atony, but as we see that the case did not really involve uterine atony, it was because of trauma to the uterus, but all in all, uterine atony is the most common complication in delivery in our labor wards. Also, we're going to share experience on usefulness and the success of B-Lynch uterine compression. Not very much, but we're also going to look at the surgical, other surgical interventions, and then also to remind ourselves on other managements of PPH options. Next. So as an introduction, I want to remind ourselves this slide. We used it during our safe surgery training, and usually hemorrhage is a notorious and a leading complication and cause of death during cesarean section, but also during, or if a mother has spontaneous vaginal delivery. And we know that maternal death after cesarean section is far more common in low and middle income countries than in the higher income countries. It's like 50 to 100 times more. And most of the time when you have a maternal death during the primary postpartum period, it's usually is caused by peripartum hemorrhage, being it antepartum or postpartum. But postpartum carries a bigger weight. And if a patient is unfortunate to lack access, and or she's late to be detected with a complication of postpartum hemorrhage, then chances of survival are usually very slim. Next. So here I wanted to put a small diagram that will show us the overall management of postpartum hemorrhage. Of course, I'm going to dwell much as today's conversation is more on the surgical management, but let us remind ourselves on other options. We know how to diagnose postpartum hemorrhage. That is more than 500 mils of blood if somebody had vaginal delivery and more than 1 liter after the cesarean section. So I'll be going forward and backwards to referring to the case. So if the obstetric team is there, we need to do rapid assessment of the patient and also to decide what do we need to do in that particular patient, because that decision or that plan needs to be communicated with the anesthesiology team. And meantime, there are some other issues that we need to do, like if you have postpartum due to atony or maybe due to rupture, sometimes you might need to start administering IV fluids to hemodynamically maintain or support the patient or resuscitating the patient before we go for surgical interventions. Now, if you have postpartum hemorrhage due to uterine atony, then you need to start administering oxytocin. And in some places, they use sulfastone, but in our settings, we usually use oxytocin in a drip of IV fluids, normal saline or dextrose, normal saline or Ringer's lactate, but should be large doses of oxytocin, between 20 and 40 in IV fluid. We also can administer, like this thing is coming up, if you have a gometrin, you can administer the drug, and I think the doses are usually from 0.5 to 1 milligram of gometrin. Some places, a patient who is conscious, you can also administer misoprostol to help the uterus contract. But if you have a patient with trauma of the uterus and you're suspecting a ruptured uterus, then the options are to secure or to order for blood products. And here we are talking about, it can be whole blood or it can be packed red blood cells. It can be frozen plasma because of coagulation deficiencies. You can add also platelets. While you prepare those things, you stabilize the patient, and then you mobilize the surgical team because the patient will need surgical management. Now, in theater, usually the choice of what should be done will also depend on the situation or the magnitude of trauma. We have seen that in Bukoba, when they opened the abdomen, they found the uterus had a bad rupture that could not be repaired. Or if you try to repair it, then probably the prognosis is usually very poor. And this is very important for the surgeon to be able to determine, because sometimes we try and think of salvaging the uterus that is probably not going to be viable. And then we end up going back to theater for the second time to go and remove it because we repaired and then it did not take up. So it's usually important to do a decision in the beginning that is this uterus, if repaired, going to survive or not? And if you find out that it's not going to survive, then we go to the option of the surgical option, that is not conserving or preserving fertility. That is, you do a hysterectomy. Now, literature and experience has shown us that to be safe, that you don't even go to injure other organs like ureters or maybe the bladder or any other very vital structures. It's suggested that, or it's recommended that you do subtotal hysterectomy, but try as much as possible to protect the ovaries, and if need be, because of the structures and also the speed of going in and doing your surgery, also you can reserve some of the tubes, part of the tubes, but please, if it is possible, preserve the ovaries, because this patient will need the ovaries for hormonal support after she heals from the subtotal hysterectomy. And if there is a need for a total hysterectomy, then it should be done by somebody who is really experienced and who can know his or her way on ways to prevent further damage or further harm to the patient. But then there are some other surgical procedures that we usually recommend. And usually the other fertility preserving surgeries would be something like B-Lynch. I know it's not a new thing for people who are trained in the safe surgery trainings. I want to mention it here again, that there is B-Lynch suture that I'm going to show you very much soon in the few next slides. And also there is the Hayman's suture that is more or less similar to the B-Lynch suture. But these are options when you want to reserve or want to preserve fertility. So I repeat again that usually the surgical management would also depend on how bad you have a traumatized or the ruptured uterus. If it is repairable, then you can do repair of the uterus. Maybe in most cases, if the rupture is so great that the baby has been extruded out of the uterus, then you'll find the baby is not viable. But then deliver the placenta, repair the uterus, and also you can do prophylactic B-Lynch or Hayman's suture to prevent the uterus from becoming atonic. But because remember, after such trauma, the uterus integrity or the muscular integrity of the uterus might not be as good as it would be if you have done a normal cesarean section, and you will end up with uterine anatomy maybe within the operation or after the patient has been transferred to the postoperative ward. So it's best if you can do also like a B-Lynch or a Hayman's suture within the theater, then you are safe. Then you can rest assured that uterine anatomy will not be there. And then also the conservative operations, that these are rarely done, but they are also there, and they can be recommended. This is the bilateral ligation of the uterine artery, or the bilateral ligation of the internal iliac arteries. These are complicated, a bit complicated surgeries, but for people who know how to do them, then that is also one of the surgical ways of managing postpartum hemorrhage. Next. Tim. So this is a picture that was taken in one of the theaters where a B-Lynch suture had been passed through the uterus because it was atonic. Next. But this is a schematic illustration of how the B-Lynch would look like. Because of for the interest of time, we know that we start on one side, maybe it's the left side or the right side anteriorly, and then you go up to the fundus, you go behind the uterus, you hook another snitch on the uterus, and then you come back through the other side. If you started on the left side, then you go to the right side, and then you come back in front through the fundus, and then you snitch again the uterus in the lower part, as you can see just there where they have repaired the uterine incision, and then you make you help the uterus to contract, and after it has contracted, then you make a knot in front of the uterus. Then after that, then it follows the normal uterine incision repair if you were doing a cesarean section. Next. So how does the B-Lynch suture help? First of all, it is fast to perform, and also it is easy to learn, and then you can make even simulations at the health facility, and it's effective. Generally, 75 to 90% of these procedures have proved to have conserved the uterus and also prevented further hemorrhage. And you can also do consecutively, like you do a B-Lynch, and then you place UBT, which is a uterine balloon tamponade after the B-Lynch, and it can help in preventing further bleeding. And this one has no apparent impact on infertility because it conserves the uterus, so the patient has a high chance of becoming pregnant again. And lastly, there is no risk of uterine necrosis if you do it very well, and then you don't compromise the blood vessels of the uterus. Next. The Hayman suture is usually, well, it might not be very interesting to read the steps, but maybe I can show you the way it looks like after the procedure. I think it's easily understood when you look at the illustration. Next. So this is how the Hayman suture would look. And remember that the Hayman suture might be placed when you have not opened the uterus. So this is probably appropriate for patients who have had vaginal delivery, as in this case, if it was just uterine atony, then I hope my colleagues in Bukoba Regional would have tried to apply the Hayman suture rather than doing subtotal hysterectomy. But for them, it was a different scenario. They had a ruptured uterus, so they ended up doing a subtotal hysterectomy because that one, as we have said, that the surgeon looked at the best option to save the life of the patient, which really happened. So we also recommend that if somebody had PPH and she had just vaginal delivery, not cesarean section, then Hayman suture is the best. Now here in the illustration, they show two sutures that are placed there, but sometimes you might have a bigger uterus, or maybe you might be comfortable to apply more than one or more than two sutures. Then you can put 2 to 4 sutures as the instruction has said. But also, I would want to go back to the subtotal. When you're doing the subtotal hysterectomy, please conserve the tubes and probably the ovaries, and just remove the uterus and up to the level of the supracervical area and leave the cervix there. It is safer and it also reduces the harm to the mother. Next. I thank you very much for listening. Maybe if there are any questions or any other things to discuss. Thanks very much. Back to you, Kevin.
Yes, thank you so much, Dr. Albert, for the very good presentation on the surgical management of PPH. I think most of the healthcare providers and the surgical teams in the hospitals have learned a lot from this. And as we now go into the discussion part, I would like to welcome if anyone has a question to Dr. Albert regarding the presentation. Please welcome. If you have any question that you would like to ask Dr. Albert. Kama una swali lolote kuhusiana na presentation ya Dr. Albert, unakaribishwa kuuliza. Okay, as we are waiting for the questions, I would like to invite our colleague from Bukoba, Dr. Jitambi, to respond to the question which was asked by Dr. Mark earlier. Dr. Jitambi, do you remember the question? Swali ambalo aliuliza Dr. Mark mwanzoni.
And I remember the question. He asked that how could it be possible the PPH was missed soon after delivery? Actually, it was missed because just after delivery of the placenta, there was just minimal bleeding, which was thought maybe it could be just local. But after some time, which the condition which alerts the providers, it just was the condition of the patient, where she developed just confusion and become restless. On assessment, we found some abdominal tenderness, and where the ruptured uterus was suspected, and the intervention were taken as presented. Thank you.
Okay, thank you, Dr. Jitambi, for that response. I don't know if Dr. Mark, you wanted any further explanation?
No, that's great. I guess I'm more concerned in general about observing and monitoring all women after a vaginal delivery and how that happens. And it's really not the surgical team. It's more about just monitoring all women after they deliver, because that's when things happen. But this team picked this up really quickly, it seemed, and managed her great. I was asking the question, what ensued prior to that, but probably not the surgical team's answer. It would have to be from somebody else at the hospital. Thanks.
Okay, thank you. Thank you, Dr. Mark. I see also Dr. Leopold has a question. Dr. Leopold.
Yes, Dr. Kevin. I just have not a question, but just a contribution. I would first thank the presenters, the team, for a good job done, and thanks to the Bugando Hub for facilitating the data. My take home from this case scenario is that we see the importance of the fourth stage of labor. I know it's a bit challenging, especially in the facilities with the low number of staff, and us where midwife is looking after so many cases after delivery. But we should now learn from this case scenario that always the first 2 hours after delivery, and that's what we call the first stage, is very important. Like what Dr. Mark was asking, had this woman been observed every 15 minutes massaging the uterus and observing the vaginal bleeding, then PPH was going to be detected less than 3 hours post-delivery. And probably there could have been no signs of shock. So to all my colleague midwives and doctors, let us always be vigilant, more vigilant actually, in the first 2 hours after delivery, ensuring that we are observing the bleeding, but again, massaging the uterus. Sometimes even teach these mothers to massage the fundus, and if they feel it is not well contracted, to report. Sometimes we do that in business facilities where we don't have nurses to be looking at all these mothers at every 15 minutes. So I was just thinking I should just insist on the importance of the 4th stage of labor, just 2 hours after the deliveries, because this is where most of the PPH occurs, and again, this is where we lose more lives, these mothers. Thank you.
Thank you so much, Dr. Leopold, for reminding us on the proper management of the 4th stage of labor, which I think to this case was very critical. Thank you so much for your comment. Dr. Albert, I see there's a hand from you. Do you like to comment or recommend something?
Yeah, thank you, Dr. Kevin. Thanks, Dr. Tibia, for the addition and for the comment. One thing which I wanted to point out today is, yes, we had a patient who had PPH, and the PPH was as a result of ruptured uterus, and it happened in one of our hospitals. As Mark was trying to look around and see that would it be easier to have seen that or maybe detected the patient's condition maybe earlier and not like on 3 hours. Maybe yes, and maybe as Dr. Leopold was pointing out that due to shortage of staff, sometimes you're overwhelmed and you don't see until a patient starts to show some abnormal features, like the way Jitambi was saying that the patient started to become restless and things like that. But also I would want to say something that much as our challenge was PPH due to ruptured uterus, but then our didactic looked at more on surgical ways of managing PPH. That's why we mentioned things like B-Lynch and everything that was not very directly relevant here, but we just wanted to remind ourselves on that, but also to see other options. I know it might not have been directly applicable in our today's case. This case probably needed subtotal hysterectomy care. I was going to say this towards the end, that we also need to be a bit cautious when we have patients delivering vaginally, not to be so comfortable. We know that we are always very worried with trial of scar, but also vaginal delivery, especially when somebody is gravida 4 onwards. Let's always be vigilant and look at our patients. We have these protocols of monitoring patients, but then we as healthcare providers, to avoid any running arounds, let's continue emphasizing or looking at our patients. Thank you, Kevin.
Thank you, Dr. Albert. I think that was a very well needed comment. Do we have any questions or other comments? Participants who would like to maybe share their experiences? Dr. Akim from Biaramlo, I think maybe I can start with you, as you are usually a very good contributor to our sessions. Have you encountered any difficult cases of PPH in your facility? Maybe you can share with us something similar to this.
Thank you, Dr. Kevin. Imekuwa sasa ni uzoefu mzuri because in our facility we get 2 cases, but all cases were home deliveries. And then after they come to our facility and we found a rupture uterus. Kwa bahati mbaya, one among these 2 was the rupture up to the liver, and intestine was torn, and the bladder also, because there's a very difficult delivery at home, but fortunately managed to deliver vaginally. And after to and the liver. Lakini tamani jua zaidi leo. Kwanza nimepata uzoefu mwingine kwamba hii sasa imeshakuwa kama inataka kuwa common, kwamba tunatakiwa kumanage kuwa monitor vizuri au kina mama wanaojifungua vaginally, kwamba hizo kesi pia zinaweza zika happen za rupture uterus. Tumejifunza vizuri hapo, lakini nilitaka niulize kidogo kwa chifu hapo Bugando, Dr. Albert. Sijaelewa vizuri kuhusiana na Hayman suture after deliveries. Mpata kwamba tunafungua tumbo kama tunavyofanya B-Lynch suture au tunafanyaje? Yani sijaipata vizuri kidogo, pengine angetusaidia kidogo. Asante.
Asante sana Dr. Hakim kwa kushare experience, na pia swali lako nadhani ni la muhimu. Dr. Albert, would you help us with the question of the Dr. Hakim?
Yes, sorry, Kevin. I was trying to respond to another need. Can I hear the question again?
Okay, Dr. Hakim, could you just repeat the question again briefly?
Asante. Tulipoongea habari za Hayman suture after vaginal delivery, sijaelewa vizuri tunaifanya kama ile B-Lynch suture, ingawa hii inakuwa tofauti kidogo kulingana na picha tulivyoiona, au kuna way nyingine ya kuifanya. Yani nilichokuwa nimewaza mimi kwamba after vaginal delivery Hayman suture tunafungua tumbo, tunafanya kama tunaanza kuapply Hayman suture. Picha hiyo hapo, tunalifungua tumbo au kuna njia nyingine ya kufanya bila kufanya laparotomy? Asante.
Asante Kim kwa swali. Thanks very much for your question. Hayman suture is done just as you would approach the uterus if somebody was doing a cesarean section. So in that, I mean, you will need to take the patient to theater, open up the peritoneal cavity, and then you access the uterus. Hold it on your hands and massage it so that it contracts, because the most reason that you're going to do the Hayman suture is uterine anatomy. So firstly, by massaging it, it will contract. And then when it contracts, it's easier for you to start inserting those needles. Remember, you're using absorbable sutures. If you have a catgut suture that has a long needle, then you're going to push your first suture in anteriorly. It goes inside there, and then it has to be pushed again. It comes posteriorly, and then you go to the fundus. So you will need to do a laparotomy for such a patient if you want to put Hayman suture, just as you will do for a B-Lynch suture. Thanks for the question, Kimpi.
Asante Dr. Albert for the response. Dr. Hakim, do you have any question? Una swali lingine lolote au unahitaji nyongeza?
Asante, nimeelewa, nashukuru.
Okay, asante sana daktari. Okay, maybe I would like also to welcome perhaps our colleagues from St. Joseph Kagondo, just to give us the experiences on the difficult cases of postpartum hemorrhage that they have encountered in their facility, just briefly, and if they have any question or recommendation to share with us during this discussion time. St. Joseph. I'm sure perhaps you must have had difficult cases of postpartum hemorrhage. Any experience that you would share with us and share with other facilities? Okay, as perhaps kwa tunawasubiria St. Joseph as they are thinking that through. I don't know anyone else who has any question. Mwingine yote tu angependa kuchangia chochote kuhusiana na surgical management of PPH. Any swali lolote?
Hello, Kevin.
Yes, Dr. Leopold, please welcome.
Yeah, just an additional to what the Biharamulo team was sharing. Just to note that imagine somebody who has a ruptured uterus with a ruptured liver and laceration to the intestine in a closed abdomen. What does that tell us? It is that there was a lot of force fundal pressure applied at home by those traditional birth attendants to try and push out the baby. Unfortunately, that the baby came out vaginal. I hope the baby also, if survived, had a lot of injuries. And therefore, we also learning here that we should not be applying a lot of fundal pressure. Can you imagine that pressure who went in rupturing the liver and then rupturing the uterus? Definitely, even the baby was born out of a lot of force and probably sustained some neurological complications. So again, in labor ward, we should not be leaning to those practices like fundal pressure. Better resort to venous delivery or vacuum extraction if we are confident with that, so that the baby gets out safe and also the uterus and other internal organs remain safe. So we can also see now the complications of fundal pressure. And as we struggle, so sometimes people does a lot of fundal pressure, still the delivery is not possible, and then they will go for surgical interventions after inducing a lot of injuries. I think I congratulate the Biharamulo team for just sharing with us this experience. It's a learning, and unfortunately it's coming from the community. So it's a learning we need to take back to these people around us, the traditional birth attendants and other colleagues, that we should go for the so-called gentle clinical practice. Yeah, not being so mechanical. Just wanted to add on that comment. Thank you.
Thank you so much, Dr. Leopold. That was very useful. It seems like if it was a fundal pressure that was being applied, really this was an extreme fundal pressure application, because to have the damage of all those internal organs with liver and intestines, that should be really extreme. So thank you so much, Dr. Leopold. Okay, we have participants from, I don't know, Biharamulo, do you want to ask something else, Dr. Hakim?
Asante, nilitaka ni share kidogo uzoefu wa hawa mama wawili niliokuwa nimeongelea. Mmoja alikuwa ni prime gravida, ametoka mbali kama kilomita 90 kutoka hospitali, na yeye walijaribu kumzalisha nyumbani. Wakunga hawa wajadi wakaja wakajitahidi, baadaye wakaita na wanaume kusaidia kufanya fundal pressure, na baadaye kweli akafanikiwa kujifungua mtoto. Lakini na aliendelea kukaa nyumbani. Siku 8 baadaye ndio alikuja kwetu akiwa na sepsis na abdomen iko distended, a lot of pus in the intestine. Kwa hiyo tulifungua tumbo tukakuta even the uterus imeshakuwa iko unrepairable, kwa sababu ile kwanza eneo kubwa lilikuwa tayari limeshaachia na usaa mwingi. Kwa hiyo tulichofanya ni kumalizia tu pale palipobaki na kufunga. Alikuwa prime gravida, lakini naye ilikuwa a lot of difficulties in delivery na a lot of fundal pressure. The second one alikuwa ni gravida 9, na yeye alizalia nyumbani. Walichofanya wao, walichukua mchi wa kupangia, nafikiri tunafahamu mchi. Wakachukua mchi wakaweka kwenye tumbo wakijaribu kufanya fundal pressure hiyo. Kwa hiyo walisukuma na wenyewe walishindwa, wakina mama walikuwa wanamzalisha. Kwa hiyo wakaita wanaume wakaja wakasukuma, kwa hiyo akasukuma kuanzia huku juu kwenye above the yani karibu na juu kabisa. Kwa hiyo wakasukuma, hatimaye kweli mama yule akajifungua around saa 10 alfajiri, lakini baadaye kama saa 1 hivi wakampeleka kliniki kwa ajili ya kuchanja mtoto, na alipofika pale kliniki akaonekana yuko anemic, hajiwezi kabisa, BP ziko chini, yuko anemic. Wakamleta kituoni, ndio tukakuta amerupture bladder, uterus, intestine zimekuwa injured, amerupture mpaka na liver. Yule mama hatukumsave kwa sababu kila kitu kilikuwa kiko vibaya mle ndani. Kwa hiyo tulishughulika naye, lakini alikufa soon baada ya kutoka theater. Kwa hiyo huyo mmoja tulimsave, lakini huyo mwingine hatukufanikiwa. Lakini ingawa yule wa kwanza tulimsave pia aliondoka bila uterus, lakini huyo wa pili. Kwa hiyo nimekumbuka hapa daktari alivyosema, Dr. Ropo, kwamba a lot of difficulties and a lot of fundal pressure at the community ilipelekea these difficulties. Asante.
Asante sana Dr. Hakim kwa kushare nasi those sad experiences of those two patients. I don't know, maybe we can discuss this a little bit and invite some others to contribute also. Perhaps maybe Dr. Albert, would you like to give a comment about the experiences of our colleagues from Biaramlo?
Thank you, Dr. Kevin, and asante Kim kwa kushare na sisi hizi experiences. Truly, naweza nikasema these are horrible practices. Sina sababu, yani sina maana ya kuwatukana wala kuwadharau TBAs, wanatusaidia to some extent, lakini let's come to a point and say kwamba, you know, these are not very safe practices. Kwa kweli naweza nikatumia ile neno kwamba they are horrible practices, na tusizi entertain. Ikiwezekana ukapata nafasi ya kuongea na huyu traditional birth attendant, mwambie tu kwamba mama, kuliko uchukue mchi, kuliko ufanye sijui fundal pressure ya style gani, bora ukubali kwamba hiyo hela ama mgonjwa huyu ni mgumu, sio kama yule ambaye ulikuwa umezoea, then send kwenye nani, ukishare naye outcomes za huyo patient. Kwa hiyo mimi I would say again, naomba niungane na kitu alichosema Dr. Leopold kwamba fundal pressure, kusema ule ukweli, kwenye labor wards zetu iwe a totally discouraged practice. Naamini kabisa wote tunaongea hapa, tunazo theater kule kwenye hospitali zetu. Itakugharimu labda nusu saa, dakika 45 kufanya Caesar, lakini ukifanya fundal pressure ili uweze kushorten hiyo delivery ya huyu mama, inaweza ikacost maisha, inaweza ikacost profession yako, na vile vile ikawa ni kitu kibaya sana kwa jamii. Kwa sababu unaweza kawa labeled kwamba wewe ndiye uliyesababisha mauti, kumbe mgonjwa alikuwa na shida zake nyingine tu, ila wewe ulisaidia kusababisha pale. Naomba ni advocate kwamba Dr. Nani ametuambia, Dr. Leopold amesema hapa kwamba let's use ventos, ama watu wengine tunaizoea kwa jina la vacuum. Vacuum extraction should always be there as an assistant. Kuliko ufanye fundal pressure ambayo ita traumatize other organs, tumia basi vacuum, mshike mtoto presenting part, na tukumbuke kwamba vacuum unafanya kwa cephalic presentation. Sio kama mtoto amekuja bridge afu unataka kufanya vacuum, that will be really outrageous. Lakini tutumie vacuum, ni salama zaidi na ina matokeo mazuri kuliko kufanya fundal pressure. Na naomba niishie hapo. Asante Kevin.
Asante sana Dr. Albert for that comment. Also, Dr. Leopold sent a comment at the chat. He's saying, let us discourage those bad practice and educate moms at antenatal clinic to avoid staying with traditional birth attendants. Kwa hiyo anatuambia kwamba to educate wamama wajawazito wakija antenatal clinic ku avoid to stay for too long na traditional birth attendants. It is from Dr. Leopold. I don't know, sijui kama kuna mtu mwingine mwenye swali au comment. Tumekaribia kufika mwisho wa kipindi. Okay. Kama hakuna swali, Dr. Albert, I would like to welcome you again to take us through the take-home message.
Thank you, Dr. Kevin. My take-home message, I had framed it this way: kwamba whenever you are delivering a patient, being it a cesarean section or normal delivery, anticipate that PPH is one of the complications. There might be some other issues, but PPH is one of the very possible complications. And that sisi wafanyakazi ama watoa huduma za afya, tunaofanya kazi katika labor ward, we all should know what to do if you have uterine atony or when you have PPH caused by uterine atony. Inaweza ikawa uterine atony, inaweza ikawa tear of the cervix, lakini PPH due to trauma, due to uterine atony, due to retained products of conception, and the other T is due to thromboembolic causes. We all need to know what to do in all those different situations. Na kingine ni kwamba teamwork is always important in trying or in achieving saving a life. Na hii itamuhusu surgeon, watu wa usingizi, anesthetists. We also need to know that the lab team is also very crucial because you will need blood products, and also the nurses around the patient. We need to make a very strong team to help save a life. And then in the first place, we are reminded, this is general, that we consider pharmacological management or mechanical compression first if you are dealing with PPH due to uterine atony mostly. Lakini wakati una apply hizo na things are not working very well, then the second line is fertility conserving surgeries ambazo tumezisema pale. Kuna Hayman suture, kuna B-Lynch suture, kuna bilateral ligation ya uterine artery if you're competent on that, kuna bilateral ligation of internal iliac, and tusisahau kuna kitu kingine ambacho ni very simple, UBT. Na UBT na yenyewe inawekwa katika hizo surgical interventions, lakini hizi ni fertility conserving. And lastly, if all those, or in one way or another, you have assessed the condition of the patient and you think you need to do a hysterectomy, but then do subtotal hysterectomy, but also conserve ovaries, and because these ones are not also important for the post-operative life of this mother. And lastly, postpartum, post-PPH care to correct deficiencies and to prevent complications. Remember kwamba huyu mama atakuwa amepoteza damu nyingi, kama hutampa blood transfusion ama kumpa hematinics ili aweze kurudi katika HB yake ya kawaida, then matatizo kama heart failure, kama cardiomyopathy, kama other complications, kama infections zitakuwa zinamvizia. Kwa hiyo make sure that you also correct all those deficiencies. And after saying that, I thank everyone for participating and for sharing your experiences for today. Back to you, Kevin.
Okay. Nashukuru sana Dr. Albert. As always, you provide very good material for the didactic and the mentoring in this echo session. So we thank you so much for being such a good contributor to our echo sessions. After saying that, lastly, we are about to reach the end of our session for today. As I mentioned in the beginning, that we are expanding ECHO to other new 30 sites. So our platform is going to be a little bit bigger now with 40 sites, and we are going to have a lot of sharing of experiences and information from all of these facilities. After that, I would like to welcome you to, unless if someone else has a question or a remark before we conclude. Kama kuna mtu mwenye kitu chochote angependa kucomment au kusema wakati kabla tunafunga kipindi, namkaribisha.
Hello, Kevin.
Yes, Dr. Leopold.
Yes, I would like to really encourage our colleagues from the spokes hospitals. As now we are expanding our ECHO platform, please be free to contribute and just enjoy learning with others. Kwa sababu naona kama michango ya vituo vingine inakuwa kidogo sana, ingawa naamini wanajifunza, na sisi tunapenda pia kujifunza kutoka kwao. Kwa hiyo naomba tuwe free kushiriki tuulize kwa Kiswahili, lakini pia unaweza ukachangia kwa Kiswahili. Lakini pia tuhimizane kwenye vituo vyetu kuwa wengi kwenye kila kituo. Sasa imagine tutakuwa na vituo 40, 20 kila mkoa, lakini kila kituo wanakuwa wamekaa watu wawili. Investment ya milioni za hela inatumiwa na watu wawili. Baadaye sasa tunakuta traditional bishop tena wanatufunga magori. Maana wanatuletea complications, sisi tunalala theater. Ni bora tukawa tuna discuss jinsi ya kwenda kusaidia jamii ili na sisi tupate usingizi. Kwa hiyo naomba tuhamasishane. Tuje tukawekeza vituo 40, lakini kila siku tunapata mtu mmoja wawili kwenye kituo. Ilikuwa ni hiyo tu, asante.
Asante sana Dr. Leopold. Nafikiri hilo ni jambo la muhimu sana ambao umekumbusha. Please tuhamasishane to increase mahudhurio kwenye vipindi. Kama unavyoona vipindi vina content nzuri na tunajifunza vitu vingi kusema kweli. Kwa hiyo tujitahidi tuhamasishane. We are sending these agendas before the session so that you can all kwa pamoja mnaweza mkaziona hizo agenda, mkajua ni kitu gani ambacho kinakuwa discussed kwenye kipindi na ukajua kama ungependa kushiriki kwenye kipindi hicho. Kwa hiyo huwa tunatuma hizi agenda na IT personnel wa vituo vyote huwa wanakuwa na taarifa ya kipindi na huwa wanatangaza kipindi kabla ya siku ya kipindi ili watu wajue ni kitu gani kitakuwa presented. Kwa hiyo tujitahidi tuweze kuhudhuria vya kutosha kwenye kipindi. Okay, baada ya kusema hiyo nawashukuru wote kwa kujoin. Nadhani tumefika mwisho wa kipindi. Tutaonana wiki ijayo kwenye kipindi cha Echo cha wiki ijayo. Asanteni sana.